An inconclusive or negative genetic testing result doesn't have to be the end of the journey. There are a few questions that come naturally. First is, have you tested to the standard of what's available?
Welcome to Epilepsy Sparks Insights. I'm your host, Tori Robinson, and here we talk with specialist clinicians and researchers to spark improved understandings of the epilepsies worldwide. Today, I'm joined by Dr. Christian Bosselmann, who is going to be sharing with us how epilepsy genetic testing results should really be interpreted, why uncertainty is common, and how genome sequencing can totally change clinical decisions. This episode is presented in partnership with Easy by Prosthesis GmbH. Who genuinely benefits from genetic testing today, and where do we still get testing decisions wrong?
So that the primary misconception, I believe, is that everyone who has a genetic diagnosis has to have a family history. The number of people who could stand to benefit from genetic testing has widened considerably. Any syndromic diagnosis, so epileptic encephalopathies, any familial focal epilepsies, perhaps even any drug-resistant epilepsies during pre-surgical evaluation. And we've done quite a bit of work on that. So, in short, most people with epilepsy.
Most people with epilepsy would benefit from having whole exome sequencing.
So that's the second major question, and that's what we still get wrong quite a bit, which is that we are now at a period in time where we really want to do first-line genome sequencing. I understand that there are some practical hurdles and challenges in implementing that, but the UK, Germany, and many centers in the US have been very good about implementing genome sequencing, and it really gives us a nice and full picture, especially including non-coding variation, like the recently described Renew syndrome, complex and structure variants. So the yield there is really quite a bit higher.
What is yield? For people who aren't familiar, what does that mean?
When we talk about yield, that's the expected percentage of people who get a positive genetic finding after testing.
So where we have answers to give to people. All right. So why is a genetic test so often mistaken for a definitive answer? Why are things not black and white?
So that really depends on what you consider an answer to be. A positive genetic finding can end a diagnostic odyssey. It can end a lot of uncertainty and guilt. It can prevent potentially harmful further investigations. So that's already a big part of an answer. At the same time, I believe the question is changing. We're becoming increasingly aware that a single genetic variant may not always be the only or even the primary explanation for a child or an adult's well-being. So the genetic background, common variants that we also have, or dual etiologies, where we have not only a genetic variant, but also another genetic variant or a structural change, both of which can explain the epilepsy. And lastly, and this is more of a policy issue, external factors, right? The socioeconomic circumstances we grew up in, so the healthcare disparities and inequalities, and the treatment-related factors. What is the consequence of what we're doing with individuals with epilepsy?
Those factors not enough taken into consideration in general. People look at, the results of a genetic testing, think, okay, that, and it's black and white, but there are actually so many other things which impact the treatment and the quality of life of the people affected.
Absolutely, yeah.
When people will get a genetic test done, and actually it's often the family that is, fingers crossed, part of this. It's not just the individual. What happens when the results are uncertain or contain a variant of uncertain significance, or VUS? What does that mean for decisions?
Both the affected individuals and their families, and we as physicians are always looking for answers. And if there's a genetic test result that says there's a variant of uncertain significance, the most common error is to assume that this should be used to guide clinical management. It is just that there's a certain level of uncertainty that means that we shouldn't consider to be directly disease-related. And that's a pitfall that we can really fall in quite a bit. There are certain variants of uncertain significance that we call hot VUS in genetic speak that are probably worth following up on. with functional testing, computational modeling, with segregation analysis of family testing. But in a lot of cases, it's just a matter of waiting to see what additional evidence comes up over the next few years.
So a person whose test today doesn't show any clear abnormalities or mutations, that doesn't mean everything's over, because in the future we might find out more.
Absolutely. And I think that's really the good news. An inconclusive or negative genetic testing result doesn't have to be the end of the journey. There are a few questions that come naturally. First is, have you tested to the standard of what's available? And that brings us back to genome sequencing. And currently, for example, TRIO, so both parents and the individual, short read genome sequencing. Then, if even that doesn't show up anything, it's reanalysis. So that's what I mentioned about waiting a bit. The genetic information in the raw data doesn't change, but our understanding of it does. The research side of things is moving quite rapidly, so we may have additional tools for analysis, better guidelines, and more information about the individual that helps us prioritize variants. And if it truly remains unsolved, if you can't find an answer even though you've been digging for years, that's where a lot of collaborative research is headed. So we have, for example, European consortia like SolveID and ADIRA, where people come together to really look at these hard-to-crack cases.
Before we move on, with thanks to Easy by Prosthesis GmbH. From your own clinical experience, what is one finding that changed how you think about genetic testing or the interpretation of the data you collect?
I think that's one thing I really want to get back to is the idea of variant interpretation, of how we start to look at these variants. And just to formalize this a bit, this is the way of how we make sense of genetic data to guide clinical management, decision-making. The most common question is pathogenicity. Does this variant provide an answer? Is it disease-related? But it can also guide management, clinical and medical treatment, for example. So that's pharmacogenomics. How is that drug metabolized? And what are the likely response rates and variant mechanisms for precision medicine? If you get a test result back that says variant of uncertain significance or likely benign or likely pathogenic, there's already been a substantial effort on behalf of the testing laboratory and the medical geneticists who go through guidelines like the ACMG or the ACGS in the UK and clarify and classify this variant. But the idea is we really want to get disease-specific insight in there. So one thing that has inspired me in my own clinical and research work has been the idea of making it about epilepsy. So finding a way that we can find new methods or repurpose existing methods to respect the genetic architecture of epilepsy and the needs of the affected individuals.
And by needs, what could that be? Because it's not just about seizure control, for instance.
Oh, no, it very much isn't. Needs in the sense that a lot of the individuals that currently receive genetic testing have particularly severe drug-resistant epilepsy, and we want to improve treatment. That doesn't always mean seizure freedom. In that case, it also means just better quality of life, better sleep, less stress, better behavior, just a whole set that defines quality of life. And to do that, we need to bridge the gap between the genetic testing report and what to actually do with it in individuals with epilepsy.
And where are we lacking that?
So this is about tailoring variant interpretation and bridging this translational gap. Unfortunately, there are things to be done, but epilepsy has a very active and engaged research community where we have tools that have been designed for epilepsy initially. This is tolerance ratio for regional constraint, very detailed sort of genetics things, but also very tangible visualizations, like the 3D structure modeling by Sumaya Iqbal, like the paralogs, where we try to gather evidence from variants on related genes, which is work that Tobias Brünner has done. And this is all presented very nice together on so-called portals. So we have web interfaces designed specifically for developmental disorders and epilepsy by Dennis Lal and colleagues, for example, that make this a reality.
And doing this work for patients and families, what are the benefits to the careers of the clinicians?
There are two very different ways that this work is rewarding by impacting lives. And it can go either direction. So, for example, I've recently seen an individual with a variant of uncertain significance in SCN8A, a voltage-gated sodium channel. That was a finding from a very old gene panel 10 years ago. And the clinical characteristics of that individual never really fit our understandings of SCN8A-related disorders. But the previous physicians were still very hesitant to give sodium channel blockers, just because she had that label on her doctor's note. And we were able to reclassify that as a likely benign variant, because things change over 10 years. She doesn't have SCN8A-related epilepsy. That came as a bit of a shock initially, because in that case, you're taking away an answer. Right? Then they suddenly start introducing uncertainty. At the same time, she received lamotrigine, a sodium channel blocker, and is doing well. So it can really go either way. Another individual with a variant in another rare gene, which was classified as a VUS for the last 3 years. And it took 10 minutes to figure out that this is a pathogenic variant. Again, because things have changed over the last 3 years. And this just goes to show variant interpretation is feasible in the clinic and at the bedside. It's not just an academic curiosity for specialists. It's you can do it, and you should do it. And I really think that we need to get that into epilepsy training better. I mean, it's out there to some degree, but especially in adult epilepsy, we have specializations in imaging, in signal analysis, in surgery. We need more variant scientists as well.
I work with lots of adults who have an epilepsy and they are refractory. They don't know why. Nobody proposes, should we do a genetic test? And it doesn't even go through the heads of the patients or the clinicians. They just don't even think about it. But the difference that could make to their lives would be incredible.
Absolutely, yeah.
Thank you very much to Christian for clarifying for us how genetic testing results should be interpreted, why uncertainty is so common, and how genome sequencing and reanalysis can meaningfully change clinical decisions and patient quality of life, and also how more and more is being discovered in genetics, which gives realistic hope to those who, as of yet, don't have a diagnosis. With thanks again to Easy by Prosthesis GmbH for partnering with Epilepsy Sparks. If you find our chat today helpful, please give us a like and subscribe to the channel, and hit the bell so that you are notified when new episodes come out, which is pretty much every week. I would personally love to hear your constructive thoughts or experiences in the comments below. Thanks for joining us, and see you next time.